Today is November 20th, 2020, and my guest is economist and physician Jay Bhattacharya of Stanford University, where he is professor of medicine, a senior fellow at the Stanford Institute for Economic Policy Research, and director of the Stanford Center on the Demography of Health and Aging. Along with Martin Kulldorff of Harvard and Sunetra Gupta of Oxford, Jay is the author of the Great Barrington Declaration, which lays out an agenda for how to deal with the pandemic, which, as we record this piece in late November of 2020, it seems to be getting worse here in the United States and in other places as well. Jay, welcome to EconTalk.
Nice to be here, Russ. Thanks for having me.
What do you think we've learned about the pandemic so far? What do we know? There's a lot of things we don't know still, but what do you think we've learned?
Let me just, there's a lot we have learned, but I want to cover just very briefly two things that are very, very important, I think, for policy that we have learned. So in the early days of the pandemic, we thought that the mortality rate, like the World Health Organization put out a number saying that the case fatality rate was 3.4%. This panicked governments around the world. There were similar estimates in places like the Journal of the Medical Association saying case fatality rate. Looking at Chinese data, 2.2%. 2 in 100 people dying from a disease is a very high number. And so the question was, is that actually right? Something that I worked on in this epidemic is to try to figure out how many people actually were infected, because a case is not the same thing as an infection. An infection is very often doesn't result in a case, in the sense that actually it turns out 30 to 40% of the people who get infected show no symptoms whatsoever. And they are very unlikely to show up at a doctor and become a case, if you will. A lot of people get mild symptoms. So it turns out, based on seroprevalence data, which is basically a study that looks at antibody levels in the population for evidence that an infection actually had happened, that they were on the order, in the early days when there wasn't a ton of testing, somewhere on the order of 30 to 40 times more infections than cases around here. Actually, in places like in India, it was like 100, I think even Kobe, 100 times more cases. Depending on the level of testing, you get a different multiplier. But it was basically the same kind of story everywhere. Many, many, many more infections than cases. And that's still true today, actually. I think it's probably not multiplier in the United States, something on the order of 5 now, because there's so much more testing. But if you look and see what the infection survival rate implied by that is, you get a really interesting story. First, you find that there's a very steep age gradient in the survival rate. People who are under 70, if now there's not 50 some of these studies, so you can criticize mine, but now you got to go after 49 other people. If you're under 70, the infection survival rate is something like 99.95%. 99.95%. For under 70. Now, it increases with age. The survival rate decreases with age, so that if you're 60, it'll be something like 99.5 or 99.4. If you're 99 point, it might even be 99. Now, if you're over 70, the infection survival rate is much lower. It's 95%. So if you get sick, you're 95% of the time you survive, 5% of the time you die. So a very steep age gradient. And I think we know that pretty well, that there's this steep age gradient in survival. For people who, let's say kids, and actually let's say people under 30, the flu is actually worse in terms of mortality. Right? So there are more kids that have died of the flu this season than have died of COVID-19, more children in the United States.
Can you comment? We're going to talk about this. We have to talk about this when we get to the declaration, but what about this fear that although the mortality rate is low, the long-term effects on who knows what, lung function, brain, kidney, people have suggested all kinds of long-run impacts. And so a college student might get the virus, survive, even without hospitalization, but have long-term damage to their body. How worrisome is that?
I mean, it's okay. Let me put it this way. So, like, if you have the flu, if you look at the flu actually also has extra respiratory consequences, right? So, like I tell this is a true story. My son, when he was 10 years old, got the flu despite having had the vaccine, and he woke up one morning unable to walk. There are very rare consequences sometimes of the flu and also the flu vaccine that are devastating that result in muscular, sort of all kinds of. I mean, I as a medical student, you go through this, you read about these rare conditions, you're convinced you have them. That's what I went through with my son, right? So, it turned out to be something called benign myositis, which resolves so within 3 days, he was up and walking just fine again. But for those 3 days, I was completely panicked, right? So it wouldn't be surprising that this disease has some extra respiratory consequences. And in fact, it does, right? So it has, like, I think cardiomyopathy is one. There's some neurologic conditions, some clotting. And I think it's very important that we study all of these things, and we're studying all of these things, trying to understand them, how to sort of treat them, and maybe ameliorate some of the damage from them. But at the same time, if you read the papers in this literature, they are terrible on the denominator. It seems really likely that these are going to be rare outcomes, just like they're rare outcomes with the flu. And we shouldn't be panicking people over things where there's still a lot of scientific uncertainty. And the most likely thing is that it's rare.
So right now, we're in the middle of a so-called surge. You could argue it's the second or the third. It looks like the third to my eye. Cases are going through the roof. I'm more than aware that cases are not the same as deaths. I'm aware of the fact that today, because of better understanding of treatment, because of higher testing, because of who gets it now versus in the past, that the death rate is much, much lower relative to the case rate, not the infection rate, but the case rate. What puzzles me, and I would love to hear your thoughts on this, what puzzles me is that why the death rate is as high as it is. So it's lower, but who is getting this now? Who are the people getting this now, and how are they getting it that it's still killing large numbers of people? And I have to say that in my casual look at the age distribution of death, and I stopped looking at it about a month or so ago, but for almost the entire run, at least during that time, the first 6 months of the virus, the age distribution didn't change at all. All those numbers you were talking about, the mortality rate, the numbers have gone down for everybody who gets it. But it's still the case that the mortality rate is very high for people over the age of 70 relative to people under the age of 70. And it's also true that it gets worse as the older you get. 80 and above is worse, 90 and above are worse. And even though getting it is less likely to kill you today, it's still the case that the deaths are in the older groups. How are people still getting exposed to it? What is going on there? I mean, is it multi-generational households where people are exposed without their being able to protect themselves? Is it people going to work and coming back to those multi-generational households? Or is it nursing homes still struggling with this issue? Do you have any thoughts on that?
Yeah, I mean, I think so. First, what you just said is exactly right. I mean, the death rates are very much focused on older people. I think there's been some work, some really interesting work, trying to characterize the risk characteristic of the population. And so if you have some chronic conditions also, you might be at higher risk. But the single most important predictor for mortality conditional on infection is age, and really advanced age. To my eye, and what you said about the mortality rate conditional on infection, even gets conditional on age going down, that's also true, right? So there's a few things there that I think we're going to tease apart. There's still a lot that I don't know, and I think no one really knows. So I'll give you my best. What my thinking is now, but obviously we'll see as time goes on. So first, why has the infection survival rate improved, even conditional on age? I think in the early days of the disease, we meaning doctors, didn't really know how to manage the condition. We thought of it as a severe viral pneumonia and not much else. We saw hypoxia, and we started giving essentially ventilators to people that really shouldn't have had them. In effect, we killed people iatrogenically with the ventilators. The other thing, we didn't really understand the sort of the immunological reaction that results in very, very severe pneumonia. So for instance, I think that the use of dexamethasone, which is a steroid that suppresses sort of an excessive immune response, has been sort of like it's really helped a ton. with managing patients. I think so. In that sense, we've kind of learned much better how to manage patients with severe condition. And so that's part of the story. Part of the story about the decline in mortality is also that because we're testing more, we're identifying a lot more people with relatively mild cases. So I think there's some of that as well. So there's some selection going on, certainly. But I don't think that's all of it. I think it's partly, it is, we actually are better at treating it. And now, let me return to the root of your question is, why is there still this?
Why are there 1,000 people dying a day in the United States, right? Over 1,000, heading towards, it looks like 2,000. Who are these folks?
So let me return to that. So I think, and this will be a good segue into the Great Barrington Declaration. I think the key thing for deciding whether a country or a state or a region has done well with the epidemic is that age distribution in deaths, because I think that's a function of policy, at least in part. Right, so a policy that seeks to protect people. Now, I don't know the full answer to your question about what distribution is of people living in multi-generational homes, nursing homes, and so on. I think nursing homes are a pretty substantial part of it, but also people. I think we see this like massive inequality in the United States and who gets infected and who dies from it. That's almost certainly, we're asking essential poor people to be essential and go expose themselves to the disease
because they have to work.
Yeah, they have to work. Whereas 52 years old, I can sit in my office and not be exposed. I think that's certainly part of it. So I think, but these are policy decisions, not just medical facts. So a country that does well, a region that does well, protects the vulnerable. That's really the key thing. And that's a key idea behind the Great Barrington Declaration, is this idea of focused protection. We need to reorient our thinking about the disease to protect the vulnerable. At the same time, we haven't talked about this yet, but I think it's going to be really important when we talk about the economics of this. The lockdowns that we have engaged in, first the severe quarantines, and now the sort of the continuing lockdowns and the extensive set of lockdowns we're now currently reimposing. Those have been extremely damaging for the population at large, not just in terms of money, but in terms of health. We talk a lot about the evidence on that in a bit. I think it's overwhelming, and it's not just the United States. This has international consequences too. Basically, every poor person in every poor country on the face of the earth has been devastated by these lockdowns. And so I think we have to sort of think about that as well when we're thinking about, because I think part of the problem, and this is I think a problem with economics, and economists have done, with some exceptions, that have done a very, very poor job of delineating the cost or the potential cost of this policy. It's probably the single most consequential policy that I've seen in my lifetime, an economic policy we've undertaken, yet economists have not engaged, as best I can tell, in our only job, which is really to point out costs, right? Isn't that our job description?
And trade-offs. I would just say trade-offs, that we've been extremely quiet. I mean, you're an exception, I'm an exception, but in general, people don't seem to be talking about the fact that this is costly. And it's not just a monetary cost. In particular, it's not a monetary cost, partly a health cost, but it's more than a health cost. It's a cost in despair. It's a cost in loss of dignity. So carry on.
I frankly am thinking about giving up my economic license if I had one, but an economist license. But since we don't require a license to practice, it's all good, I guess. No, it's been dispiriting actually to see economists not engage wholeheartedly. I think partly because this is a medical thing, and people, I think economists have been reluctant because it doesn't fit our area of expertise. We're arguing with doctors and epidemiologists, and so we sound crass when we do it. But I think we as economists have an obligation to point out these trade-offs, Russ. Absolutely, and there are so many that it's beyond one or two people to point them out. I really believe. I think this is the single most consequential economic policy decision in my lifetime.
But let me press you on that, because I think there's a temptation on the part of some of my friends who are like you, worried about these other costs, to confuse government mandates like schools are closed, no restaurants, no concerts, no gatherings of over 25 people, et cetera. Those are government policies but there's also the personal response that people have voluntarily chosen. So even if it were, I think it's legal to go to a bar in Maryland where I live right now, but I wouldn't go. I wouldn't go in. I would go outside. I would wear a mask. Much of the restrictions that people are dealing with, which have economic consequences, are personal choices. So I guess the way I would ask you to frame this is, if you had been president of the United States in March, would you have given a statement akin to what I understand Sweden did? What I understand Sweden did is they said, look, we're not going to close anything. It's up to you, citizens. Be careful. Don't do anything stupid. Don't crowd into a crowded venue without a mask. And just, especially if you're old, and if you're old, stay home as much as you can. And if you can't stay home, find a way to get help so you don't have to go out. And do you think that's what we should have done? Because I think a lot of the costs of this pandemic have been the personal choices that people have made in the absence of full information. How do you feel about that distinction? Am I right?
Yeah, no, I think I've written on that actually in the context of the H1N1 epidemic from 2009. I mean, I think that's in fact, that's the sort of one of the key animating ideas of economic epidemiology, is that people respond voluntarily to the risk they perceive.
Yeah.
And I've been following this literature that economists have been having on what fraction of the economic harm from the pandemic is due to this sort of how much would have happened just because people responded versus, and the estimates range from like 10% of the harm to 80% of the harm. I don't think there's any consensus yet.
It's a little wide.
Yeah. I mean, let's even take the low end. I mean, for sake of discussion, we can even take the low end if you'd like and say 10%. I think one like sort of just a little tweak on this, on the way you've framed it, Russ. The panic itself is a policy decision. It is. You can see it in the way you talk about Sweden, right? So I think Sweden in the early days did a very poor job, especially in Stockholm, protecting its nursing homes. That's why it had a very high death rate early on. Later in the epidemic, it did this much more, let's give good risk communication to the population, describe things that you might do to protect yourself as best we can, and then let the population do what it wants. That's one approach. The other approach is the approach that I think the United States and many, many other countries took, which is essentially to say the world's on fire, stay inside, panic, you're going to die if you go out. I think this has had a huge, I mean, that's a policy decision, right? So in a sense, the economic literature on this misses the point. If it's 10%, it's 10% because we decided to tell people that it's the world's on fire.
Yeah. So right now it's November 20th. We're 6 days before Thanksgiving. The CDC announced today, don't travel for Thanksgiving. Don't go home. Don't celebrate the holiday. Stay home by yourself and your immediate family if they're around. My mom is 88. She's sitting by herself in Huntsville, Alabama. Thank God she's healthy enough that she can live independently, but we're all worried about her. And she was going to go to Memphis to my brother and sister for Thanksgiving. We had thought about even joining her there. And now we've discouraged her because the world's on fire. And the part that's strange about this, it feels like because the cases are rising so dramatically and the deaths are rising, even though at a slightly less dramatic rate, they're rising, it feels like the disease is worse than we thought. Now, it's the same virus, obviously. It's not any worse than we thought. If anything, it might be milder as it mutates. At least we had hoped that originally. But it suddenly feels worse. And people are making decisions based on that emotional reaction. Some people listen to the CDC as if they are coming from Mount Sinai, the mountain, not the hospital. And some people treat the CDC like a clown show, that, they don't know anything. They're just a bunch of fake experts. So we're kind of, I mean, you say it's a policy decision, but the truth is that we're in a very messy time for expertise and knowledge. And again, as somebody who's somewhat skeptical about overreacting, I'm more scared now than I was 2 weeks ago, for better or worse. I don't know if it's I'm not reacting so much to the policy environment as to my perception of the data, which is probably maybe a mistake.
No, I mean, I think, look, one of the jobs of public health is to accurately communicate risk to the population. We shouldn't overstate or understate. And so let me just describe what I think of as the huge mistakes that public health has made in the United States and many other countries, actually. So I don't think it's simply the United States. So one, we have given this impression that everyone is at the same risk of death, conditional infection. What's that led to is my 80-year-old mom is she is a very social person, and she absolutely hates not being able to talk with her friends. It's been isolating. She lives essentially by herself in Southern California. It's really been difficult for her. She's lost weight. It was not good for someone that's 80 in that sense. It's been just a traumatic thing to have to be alone all the time.
It's horrible.
But for her, I've told her what the risk is, and I think I've done a good job with that. And she can make her own choices based on that. But for many older people, they underestimate the risk because we've told everyone they have the same risk. Whereas for many younger people, they vastly overestimated their risk. Right? So we've done a very poor job conveying what really people in different walks of life, what their risk really is. That's a public health failure, right? That's communication by public health authorities. People don't trust them because they've done poorly. I mean, let me give a couple more. Sorry, Russ, you're going to
keep going. No, keep going.
So another failure, I think, of public health. We should never stigmatize anyone with a disease, and we should not create a sense of shame because you had a disease. And public health has done a absolutely terrible job at this. If someone gets COVID, it's because they failed. They weren't wearing a mask. They walked around when they shouldn't have. They did something wrong. That kind of stigma does not belong in the public health toolkit. And it's divided people in sort of very distressing ways, right? So you walk around, you see someone without a mask, you think, oh, they hate people. That's not right. We should not be creating a situation where, masks, the evidence is mixed, honestly. I mean, there's some evidence that it does well, and it's not a panacea, obviously. You can get sick even if you wear a mask, again, obviously. We shouldn't be creating this sort of sense of division as a public health community around these actions. I mean, they're not. I'm not saying don't do it. I mean, I wear a mask in crowded places. I tell my mom to wear a mask. I mean, I think I'm not against it, but we shouldn't create a sense of stigma around it. We should create a sense of compassion for the people who have the illness. That's really vital to public health, or else you end up with a situation where the situation we're in. Because now it's not just that you get sick; there's a stigma of failure around you becoming sick. So there's that, and the third big failure of public health has been this sort of lack of imagination in how to protect the vulnerable. We've decided that when we're going to talk about the Great Barrington Declaration, I can talk more about that in some detail. But that is shocking to me because the public health folks I know have spent their careers thinking of ways to protect the vulnerable from a million other diseases. Why this one disease, all of a sudden we've thrown up our hands and said, no, we can't do it. I think that's not right. I think there are concrete things we can and should do immediately, actually, to do this. Actually, the vaccine presents enormous possibilities for that. But I think, and partly I think that's been driven by this, and you've mentioned this several times, Russ, this like rise in cases creating panic. The thought behind the epidemiologic response to this, it has been that if we control the number of cases, we can reduce the risk the vulnerable face. That is an evident failure, right? The rise in number, it's very, very, very difficult, or maybe even impossible, to control the rise in the number of cases in places like Europe, the United States, and the Americas, right? The disease is already too widespread. By the way, I want to just a little like side thing. I don't actually think it's a national condition. I think this is a regional disease.
Right. Yeah. It's bouncing around.
Yeah. So right now we're seeing it's like the Midwest. Really, that's really where the biggest cases are. Right. So it's and so in a sense, like, and actually that's true in most places. There's a few places where it's come back, but I'll give you an example. Like in Italy, in Bergamo, which was the sort of the center of this. Lombardy as a whole has seen a rise in cases in the second wave, but Bergamo itself, that saw a massive first wave, has not seen a very large rise in cases. So I think it's one of these things where like it hits an area and really hard, and it can come back some in that area, but it's going to come back less sort of milder the next time. And I think that's what we're kind of seeing in the United States. It's sort of bouncing around the country, and it's sort of the Midwest's turn this now, unfortunately.
Go ahead. I want to respond to something you said about the mask, but do you want to say something else?
Yeah. So the other thing I think that we failed at, the public health has failed at, is public health normally has deeply embedded in it the sense of like the Swedes would call it solidarity, or so this abhorrence of inequality, and public health has done a very poor job in its. I mean, as we talked about earlier, it's sort of sought to protect the well-off in its its decision making about so like the lockdowns, for instance, the quarantines. We already said exempted essential workers, essentially poor. It's located in the initial days. It located testing sites in areas where there were a lot of rich people, and not very many minorities. I think we have done as public health, we have sort of forgotten something that should be in our DNA, which is we ought to be caring for the least of us in some sense, as part of our how we think immediately, and we sort of
the least well off. Yeah.
One other piece of evidence on masks. So there was a study that was just released out of Denmark.
Yeah.
It was a randomized study where I think it was about 5,000 people. 2,500 had masks, randomly assigned. 2,500 didn't. Early in the epidemic, when most people in Denmark weren't wearing masks, and so it's a test of whether the mask would protect the wearer, not slow the spread of the disease. And if you do that, if you treat that intervention as if you treated it was a vaccine, you'd say it was a 14% efficacy, right? 2.1% of the non-mask wearers got the disease, 1.8% of the mask wearers got the disease, and it's not much of a difference, right? It was not.
Well, I wouldn't say that. You said what was the ratio?
2.1% versus 1.8%.
2.4 or 2.1?
2.1.
Yeah, well, it's not so much. 10%.
It's about 14%. So it's like if you calculate it the way we calculate vaccine efficacy, it's a 14% efficacy intervention. And again, with massive standard errors, but whatever.
Yeah, but the problem with all these kind of quote tests are that they're very specific to certain situations. I think the most appalling bit of evidence on this question came out when there was a study out of Duke University on different kinds of masks. I'm sure you saw this, and they announced that the gaiter, the neck thing, didn't help at all. It may have made things worse, and then they speculated on why. And people immediately, my synagogue immediately banned neck gaiters. If you can't wear a neck gaiter if you're coming to services, it's because it's dangerous. And you look at what?
Bandanas are bad too.
Bandanas and neck gaiters, yeah. And I thought, that doesn't make any sense. And I looked at the actual study, and they had one neck gaiter made out of fleece, whatever that is. I've never seen a neck gaiter made out of fleece or a bandana made out of fleece, but okay. But it's so uninformative. It never should have been, that line should have been excised from the study. It maybe they had all the caveats, I don't remember. But the newspapers ran with that, as they have with most of these things. And so I think a lot of the ignorance and over and underreaction both have to do with the challenging times we're in. And I alluded to this earlier, that there's nobody to trust. A bunch of people are trusting. A lot of people don't trust anybody. There's other people who trust people who aren't trustable, aren't reliable. And there's a handful, presumably, of trustable sources that are reliable, and they're being trusted by a very small group of people. I don't know. It's a very unfortunate time. But to go back to the main thrust, you're arguing that we've overreacted. We've pushed a set of reactions and actual policies that have tried to protect the population as a whole. That comes with an enormous cost for the least well-off among us. And we should have devoted most of our effort to protecting the most vulnerable. And if we could have avoided, and still can avoid, much of the cost that's falling on poor people and on people who aren't nearly as vulnerable. Is that a good summary?
Yeah, I mean, the only thing I tweak a little bit is we've completely over. I mean, I don't think we completely overreacted. I think it's a serious condition. It warrants a very, very serious policy response. So but I think what I'm proposing is a very serious policy response.
Okay, so let's get to that. But I just want to say, one more thing. I got characterized mistakenly as somebody who's skeptical of lockdowns. Well, I'm somewhat skeptical of lockdowns. I can imagine situations where it's the right thing to do. What is really dramatic to me and tragic is many of the countries that locked down rigorously did things that were much more dramatic than happened here in the United States. And I'm particularly thinking of Israel. Israel had a very severe lockdown where you couldn't move. A lot of people weren't allowed to literally go outside unless they had an emergency or they had to walk a dog. People tried to acquire dogs for that reason, of course, economics in action. But they were very successful. That lockdown really shut down the disease, and everybody celebrated. And they went back to their life, and then it surged again. So they've locked down again, and I think people think that, and let's pretend there is such a thing as a rigorous lockdown, meaning really works. It's not just a policy. It actually, either because you use the army, as China did, or people are very obedient, they don't go outside. The tragedy here is it's not clear that it has any much effect other than the short run, which is useless. So you only get the costs of the lockdown, the loss of economic activity, and then the loss of well-being that comes from that loss. And then you don't get any of the benefits because all you've done is just, you've turned the light off. The disease is still there. When you come out of it, the light comes back on. It's like, oh, there it is, had gone. Is that what's going on in many places?
It's exactly what's going on, Russ. It's exactly what's going on. The math of these compartment models is very, very clear. So let's say you have, in theory, a entirely effective lockdown that slows this, basically flattens it. When you lift the lockdown, the disease is still there, floating around, asymptomatics, and it comes back. And this is a worldwide thing, right? If there's even a little bit of international travel and one country has a few cases, it's going to come back as soon as you lift it up. And the math is very, very, very clear, right? As soon as you lift the lockdown, the diseases will come back, and the integral over that curve is the same number of cases. That the lockdowns just delay when the disease happens, it doesn't eradicate the disease. Lockdowns have never eradicated a disease in the history of mankind.
But I'm a little puzzled by that. And of course, some people have argued, I think, rather monocausally, without much thought to the fact that the world's a complicated place, that, these countries, fill in the blank, could be certain Asian countries, could be Australia, New Zealand. They did this right. They figured it out. They've locked down or they've restricted movements, and almost no one died in these countries. And the United States should have emulated them. So you don't agree with that?
No. Well, let's just take New Zealand, right? So I think the problem with that reasoning is that it's very clear in that those places, when they locked down, there were very few cases around. By February, in the United States, in Europe, and the Americas, that was already too late, right? So the lockdowns, the theory of them is that you reduce the number of cases to the point where you can do a testing and tracing regimen that actually has some hope of capturing all the cases, and you get zero COVID. Right, that's New Zealand. They locked down very early, very hard, and they did a very rigorous testing and tracing program. There was a little resurgence in July where everyone panicked when there was a few cases, and then they locked down again. And the next time someone comes, and every time someone flies into New Zealand, they're in a 14-day quarantine, or whatever. I'm not sure exactly the exact policy now, but something like that. And you end up with a situation where you have basically to be isolated from the world forever. That might work if you have very few cases to start with. By February, when President Trump issued this travel ban from China, it was already too late. And it was already too late in Europe. It was already too late in the Americas. Right? It was that policy cannot work when disease is already widespread.
But shouldn't it kind of die out? I mean, the part that the original idea behind the sheltering in place or the quarantine or the lockdown was to, quote, flatten the curve, that the integral would be the same, the number of cases and would be the same, but the hospitals wouldn't be overwhelmed. And there was a logic to that. But I noticed this in my own mind as well, that made sense to me, reasonable idea, that you wanted to make sure that you don't, not only that you don't kill people who have it because they can't get a hospital bed, but the people who have other conditions can now also have an issue with getting a hospital bed. So smooth it out. Good idea. But it was very shortly after the smoothing out idea caught on, I started to hope, maybe we'll just kill it off. Because if we stay in place for X weeks and it can't spread from person to person, then by the time we come out of the lockdown, it will be dormant and it won't spread it. Is that not true?
It's not true. It's too widespread already.
But how is it going to spread after? Let's just take just a silly example. If everybody with the disease doesn't go outside for 2 weeks, and they don't have is the problem is that even though they're not symptomatic, they still spread it.
Yeah, there's asymptomatic spread of this disease. We know that for a fact. So Peru is a good example of this. Or maybe Argentina. Like they've stayed locked down pretty sharply through. I think Peru, they actually had the military enforcing it, and yet they've seen the highest deaths on the face of the earth per capita. They've had the disease continues to spread. It's not like we talk about lockdowns as if there's like theoretical thing where we literally just sit shelter in place forever and isolate. That is not how lockdowns actually work. Humans have to interact with one another, and those interactions will spread this disease. It's an incredibly infectious disease. It's not possible to get to zero COVID.
Well, there would be if we could all just cryonically freeze ourselves for X number of months, but we still have to eat. We have to get to the grocery somehow, or the food has to get to us. Somebody's got to collect the food, pick up the food, drive the trucks. There are these, quote, essential workers who are going to be out in the world. They have to be, otherwise we'll die. You can't literally lock down. That's the real way I understand what you're saying.
Yeah, take care of cancer patients, teach our kids. I mean, there are absolutely essential things that have to happen, right? So I think that it's like the shimmer. You think of this like thing that we can't. If we just had this ability to do this, it would be a perfect world. But economists as a whole, I thought, were immune to that kind of thinking. It's just not possible. So I think that dream of zero COVID has caused so much harm, Russ. We have no choice. We have to learn to cope with this disease. It's grim and unfortunate, but we just have to figure out the best way forward, muddling through. And there really isn't, and promising people zero COVID, I think that a lot of the pathology of the last 11 months or 10 months or whatever has been around this. People won't say it explicitly, but they have it in the back of their heads. And they've generated support for these policies that are absolutely devastating. We still haven't talked about some of those costs, but they're absolutely devastating, and without any hope of actually achieving the end that they won't even state out loud.
No, the implication is that if we'd had a wise leader, we could have had zero deaths, and I think that's kind of a fantasy. We can debate how many deaths. It'd be a foolish debate, but we could debate how well or poorly the president handled this crisis, and I think he handled it poorly as a leader. Whether he handled it poorly as a policymaker is I think a much, much more complicated question. And he did some good things and some really stupid things, I think. But so did everybody else. But we're not going to talk about that. I'm not interested in that at all.
And it's a dumb debate. I think that the leadership is not the key thing. It's the ideas underlying the policy, really the key thing.
So let's talk about the costs, and then we'll segue from that into this question of how to protect the vulnerable in ways that reduce those costs. So what do you think? Talk about the costs.
So let me just so people who heard me have heard this litany. So I apologize if you've heard me before, but let me just align some of them. So just to get some sense of the scope of it, right? So in April, the UN World Food Program, I think the group that won the Nobel Prize, the Peace Prize this year, estimated that there will be an additional 130 million people who will die of starvation worldwide this year as a consequence of the lockdowns, right? A consequence of the economic harm from the lockdowns. I think the calculations are very simple. It's like, you just figure out what the economic hit is for a poor country. There's some distribution of income, what fraction goes below $2 a day of income or something, and say, okay, that person's now at risk of starvation. 80 million people thrown into poverty. So we've had I think in the past 20 years, 1 billion people lifted out of poverty. That's reversed or starting to be reversed. Again, worldwide, tuberculosis, I think up to like 1 million more deaths because tuberculosis control programs have been stopped. Polio has resurged in Afghanistan and in Pakistan because the vaccination programs we actually were on a track to eradicate polio, and that's been reversed. In fact, Gavi, which is this massive vaccination campaign worldwide, was stopped. MMR vaccines.
But is that stopped because of a policy mistake or the existence of the virus?
It's a policy decision, right? So you decide that the virus is too dangerous to send people out, or you don't have the resources. Those are policy decisions. Because maybe is COVID worse than measles, mumps, and rubella, diphtheria? I don't know. I mean, it's one of these things where we've just decided that this is the worst condition on the face of the earth, and we're just going to throw aside so many of these things we thought were also deadly. In the United States, 1 in 4 young adults seriously considered suicide this June. 1 in 4. Normally it's something like 4 or 6%, 4 to 5%. It's 1 in 4 this past June. Again, now for young people, this is absolutely devastating. Like, lockdown's a devastating thing. Young people, not me, I'm a hermit, but like most of the other young people I know, I knew when I was little, they all like to interact with one another, and it's psychologically. I mean, I've seen it in my kids. Like the one success I've had is my wife and I. We convinced our neighbor to let their kid play with our kid during the epidemic, because kids actually are very low risk from this, and I don't actually spread it very high. The risk in schooling. I mean, the U.S. closing its schools is absolutely devastating. It's actually out of line with the rest of the world.
You're suggesting that's insane.
Yeah, it's absolutely. It's absolutely has no basis in science whatsoever. There's an estimate that was just put out in JAMA that because of the loss of schooling in the United States for our kids, they will lose because schooling investments are really, really productive. They result not just in higher income later in life, but also better health. The estimate is that 5.5 million life years lost for our school kids this year.
Yeah, I don't believe that at all, Jay, but that's a subject for a different conversation. But what I do agree with is that the loss of learning, so mostly, and also just the socializing part of it. It's I watch little kids again in my synagogue. We are praying in our parking lot, and I watch them, 4-year-olds and 6-year-olds in masks, not getting close to each other, and it breaks my heart. Now, if my kids were younger, they're not, but if my kids were that age, I think I'd probably put them in a mask and tell them to stay away from people also. But you're suggesting that's not good advice?
Yeah, the kids spread the disease much less efficiently for reasons we don't fully understand, but it's just an empirical fact. And they die at very low rates from this disease compared to other things that they face.
The hard part of that is that, as a parent, you think, well, they die at lower rates, but doesn't matter. I want to make them safe. And I think it's hard to see those costs on the other side.
I would send my kids to school. I mean, my kids I told you my son got flu, right? It's that the flu is more deadly for kids than COVID.
Right. And we don't close school in the winter in America.
And, I have reason. Like I saw my kid unable to walk for 3 days because of the flu. Yeah. But the school is more important to him and his life than the small reduction in the risk of death from these diseases. Just is. I would send my kid happily in person to school today.
Let me ask you a related question. We've gotten the major sports in America have all coped with this in a slightly different way, but generally they've closed their stands. They don't have fans live. They've put a bunch of restrictions. Some sports, basketball actually had a literal quarantine of the players in one space. Other sports have done more testing. And of course, a lot of football players, where they're not quarantined in place, have gotten the disease. I don't think anyone's died of it. I don't think
zero died. Yeah, and
right?
Cardiomyopathy. I think one Major League Baseball player, but he had pre-existing cardiomyopathy. I mean, we haven't seen the long-term effects. I think it's interesting, right? I mean, I think this, and actually, you might ask why reopen sports? I mean, of course, there's money involved, but there's also there's a lot of psychological benefits to people from having this. It's part of what life means to some people. I mean, it's part of I don't think it's nothing.
I mean, unless the Patriots are having a horrible season. I mean, I would have hoped they'd kind of just shut down the whole season this year in football, and I'd be spared a 2-5 start. But I get your point.
My Red Sox were so terrible. I almost regretted.
Right. Why didn't they shut that thing down? But okay, yeah, no, I agree with you. Of course, the human side of this, the idea that only thing that matters is reducing the risk of disease as much as possible, is an insane idea that only a doctor can love, and that an economist, you're right, should rebel against, because we understand that there are costs that are not unimportant.
People stayed home from cancer treatment because they were more scared of COVID than cancer. That happened this year. Mammography drop, I think, on the order of, I think it's like 70-80% reduction in mammography.
People are afraid to go to the hospital.
Yeah, and just colonoscopy, like no one likes it no matter what you do. And then you give people, they say COVID, you might get COVID, and yet they have this fear, right? Even though they won't. And they won't go get a colonoscopy. We're going to see stage 4 breast cancers rise in coming months. We absolutely will, because mammography prevents late stage breast cancer diagnosis.
Well, I'm more skeptical about that too, but again, that's the subject for another thing. I mean, I think there's another time. There's a lot of, we'll see in the data.
It's one of these things, like it's a priori, you can't just dismiss it, right?
Agreed.
We have seen this decline in mammography. That's a fact. What the consequences are, it remains to be seen. I believe in mammography. I think the evidence on mammography is very effective in early diagnosis. So I think that's why I pushed this line. In any case, you're right, it's an empirical fact, but it's something we shouldn't dismiss out of hand.
No, I criticize it only because the evidence for it, certainly at younger ages, is very mixed in terms of actual survival rate. False positives are a huge problem. Intervention's a huge problem that's not effective. But that's a different issue. I think you and I agree that there are many, many consequences of this reaction that we have that we're enduring that are not measurable as deaths yet, that are not trivial. But let's get to the declaration, which has been quite interesting in terms of the reaction to it, and I'm sure you've had some challenges, which I hope we'll talk about. But lay out lay out the centerpiece of the ideas behind the declaration. It's called the Great Barrington Declaration, and at the heart of it is this protection of the most vulnerable. So that after you've laid that out, tell us what we should be doing and should have done for the most vulnerable.
Yeah, so the Great Barrington Declaration, it's as you said at the beginning, I wrote it with Martin Kulldorff, who's a fantastic epidemiologist at Harvard, and Sunetra Gupta, who's probably the world's premier theoretical epidemiologist at Oxford. And then they agreed to include me, which is still a mystery to everyone. The declaration basically says that it basically is a response to things we've been talking about. The key idea is that the lockdown harms are worse than COVID for the non-vulnerable, meaning younger people with few chronic conditions or whatnot, and for the older population, COVID is more deadly than lockdowns. We spent trillions. The central idea then is let's spend those trillions to protect the vulnerable. And you can do this. There's some concrete ideas that we put forward, but I was hoping that the public health community would engage with this more. And I actually think it's kind of started to do so. So one is protect the nursing homes. That's the most obvious thing. That's where a lot of the deaths have happened. And there's concrete things you can do, right? So you can test staff members. If you have a staff, it's actually pretty common for staff members of nursing homes to work in multiple nursing homes. So reduce that from happening. Reduce the number of staff members that an individual in a nursing home sees. Test visitors. Now, you have to balance that with loneliness, because that is a major problem in nursing homes.
Horrible.
Yeah, so you have to figure out some way. And I think, actually, nursing homes, to my eye, in some places have started to do better. Like, we haven't seen the deaths we saw in New York and New Jersey in the nursing homes. That was a really big mistake, right? Sending COVID-infected patients back. If you get a COVID-infected patient in a nursing home, have a ward or place where they can be isolated from the rest of the people. I mean, just simple ideas, PPE. All these things are really, really important tools. Not all of them perfect, but they're useful tools and vital to use in this setting. For people who live at home alone and older, we have these like grocery hour for older people, but then they still interact with a lot of people outside where they're exposed. Why not use the trillions we spend on, grocery deliveries for old people?
Yeah.
Actually, you don't even need to wait for the government to do that. If you know old people in your community, go just ring them up and ask them, "Can I help you with that?" Another thing is is people who are essential workers that are older and at high risk. The 63-year-old janitor with diabetes, right, or the bus driver or the Costco clerk or whatnot. Why on earth did we decide that we can expose them to the virus? That is absolutely. I don't have the right vocabulary to describe how I feel about that policy. Instead of protecting those people we know to be vulnerable, we said go out and work. You have to make now a choice between. And there are policies and laws in place that we could use to protect them, like the ADA. We could have declared them a disability for during the pandemic, because you're in this vulnerable class, and they could then the employers could provide a reasonable accommodation. So the school teacher who's 62 and has these pre-existing conditions that make them more likely to die if they get COVID, they can stay at home, teach on Zoom, help younger teachers with curricula, whatnot, and younger teachers can go teach in person because they face such little risk.
Yeah, many private schools, I think, are doing just that voluntarily.
Yeah, I mean, I think there's no reason why that we couldn't have used our policy levers to try to do that. For multi-generational homes, it's still a problem in the United States, but it's even more of a problem outside the United States. And like in India, it's a huge problem. It's a lot of the older people that got the disease got it in multi-generational homes in India. But in the United States, and actually in many places, the lockdowns actually created multi-generational homes.
Right, because people lost their...
Yeah, young people lost their jobs. They went back and lived with their parents. We closed our universities down. We sent a vast number of kids back home to live with their. I mean, I personally benefited. It's been fun to have my 19-year-old daughter come back home.
Yeah, I loved it.
I mean, and I'm happily take the additional risk of COVID because she's going to do 19-year-old things. Fine. But we've created this risk. How do you address it? One, stop the lockdown. The lockdowns created the risk, and the unemployment and dislocation for lockdowns, at least in part, even if it's just 10%, created this risk. Second, you can use testing resources like these rapid antigen tests. One of the major problems has been that we have this like regulatory apparatus that makes it very difficult to get at-home tests that you don't have to report to the outside. And you have to go to a lab to go get a test. And the thinking has been, well, let's find every case, test and trace it, and go to zero, right? But that's prevented people from getting tests. I mean, I don't want to go tell on my friends if I don't have to. I'd rather just be able to tell when, if my 80-year-old mom is going to come over, I want to be able to tell if I'm positive immediately on the spot. There are rapid antigen tests that you could do that where you don't have, in principle, you wouldn't have to go to a lab to do it. We should make those very, very widely available. And then people could volunteer. I mean, if they report it or not report it, that's not the essential thing. It's do they act on it in ways that are reasonable for their situation?
Yeah, we had Paul Romer on here talking about that. Obviously, not everybody's going. He's been pushing for more tests availability, knowing that not everybody who gets a positive test is going to act responsibly. There will be people who do irresponsible things even with a positive test. But it'd be better to have more people aware of that they're putting other people at risk.
That's completely reasonable. And I mean, it's a policy decision we made in part because of this zero COVID aim, right? We said, let's identify every single positive person and then work epidemiologically, like isolate them, quarantine them. We've created the situation people the cost of taking a test is not simply a medical decision or a personal decision about like, am I going to expose my mom or not? It's now a huge economic hit. If I'm positive, 14 days without work. Right, or whatever it is. I mean, whatever the regulation is in your neighborhood. In any case, it's a huge cost. And then I'm contact traced, so I have to be interrogated about every single person I've interacted with. And sorry, Russ, I'm going to give you up because we talked on Zoom. So it's just I mean, I think it's one of those things where like we really haven't thought about the economics of it in terms of the incentive that's created this testing measure. In any case, I think there's lots of like creative ideas you could do to protect multi-generational people living in multi-generational homes. You can make hotels available for someone who's sick inside. If my 19-year-old sick, maybe you allow my 80-year-old grandma or 80-year-old mom to like go live in a hotel for a brief time while she gets better, and then while my 19-year-old gets better, and then they can come back. I mean, I think there are a lot of policies we could have adopted that didn't adopt because we didn't think about protecting the vulnerable. We thought that only controlling the spread of the disease would be the way to protect the vulnerable, and very clearly that's not true. So that's the Great Barrington Declaration. The other half of it, and probably you understand, right? The lockdowns are worse than the disease for the non-vulnerable. I'm not saying let intentionally get infected. I'm saying let them live their lives so they don't face the lockdown harms. On net, we're doing them a favor because the lockdowns are harming them more than the disease.
So you're saying that if we had been more sensible both in the communication of the risk and the treatment of the more vulnerable, that people who say work as a bartender or a barista or a clerk in a small store, those people could still have their jobs because the people who would engage in commerce, the eating out, the drinking, the picking up something at the hardware store or the grocery, those would be people who were not so much at risk. They might get the disease, but they're very unlikely to die from it. They might in turn infect the clerk, but that clerk's very unlikely to die from it. And now what we've done is we said to the clerk, we're going to reduce your risk, we hope. In fact, we haven't, but we're going to reduce your risk to what we hope is zero, and you're just not going to have a job, which is not attractive.
Yeah, it's not going to have a job. You're going to face the depression that comes with unemployment. Maybe you'll miss your health insurance, and now you won't be able to get the cancer screening that you would normally have gotten. Or, there's a million knock-on effects. The economic harm has these, results in less trade so the developing countries, the price of food goes up in developing countries, so you get more people at risk of starvation. I mean, there are all kinds of knock-on effects. The economy is not just a simple one-off thing. It's like deeply interconnected. We've seen that, right? I think that's one thing we've learned from this epidemic, how deeply interconnected it actually is.
We have a wedding coming up soon in my family, and I don't think my 88-year-old mom is going to attend that in person. I think she's going to watch it on Zoom. And that's, I think, okay for a lot of reasons. It can't be as joyous a wedding as it would have otherwise been. So what she's missing is not as exciting as it might have otherwise been. But if she said to me, I want to be at that wedding, I would say, come, because she's 88. She might die tomorrow, God forbid. I hope she lives for 10, 20 more years. But I would never say to someone, to preserve your life, you should skip every life cycle event for the next X years till we found the vaccine or this thing's disappeared. And I think the other point I want to make, which I think is, you sound horrible when you say it. I'm going to say it anyway, because like you said, we're economists. There are things worse than death. I'll say it a different way. We're right now on the cusp of getting a vaccine soon. I'm very excited about that, obviously, because I think we're going to be able to travel again, maybe lead a somewhat normal life. And, but what really is unfortunate? Even if there is a vaccine and I take it and it works, I'm probably going to die anyway at some point. It's hard to remember that. What this pandemic has reminded us of is that we're mortal, right? But it's a weird kind of remembrance of mortality. It's like, I just got to get through this. If I can just get through this horrible plague, then I'll get to the other side and I can have normal life again. You will, but it's still finite, which is just an unpleasant reality. Actually, it's not even unpleasant. It's just a fact. It's how we live as human beings, and we should live our lives accordingly. We should enjoy what we can. It's all temporary. It's important to live fully.
Yeah, we live in the shadow of death. But we should live in the light of life, right? That's really and I think we've darkened our vision with the shadow of of higher mortality from COVID, and we've shuttered the light altogether for so many people. I think that's really the heart of the mistake we made in this policy.
So you had the courage to sign this statement, co-write it with two other people. It was a brave thing to do. I want to salute you, because I assume that you've gotten some hate mail, maybe some death threats, because obviously if you think that we shouldn't lock down, you're obviously a callous, horrible, heartless person who doesn't care about human beings. Is that a fair summary of what's happened to you, or am I being overly dark?
It generated a huge reaction. I mean, I kind of anticipated the reaction. I say early in the epidemic, when I worked on these seroprevalence studies, I didn't anticipate the reaction. So I kind of wasn't quite ready for that. But this time I was more ready, sort of emotionally, to deal with it. I don't regret signing it at all. I mean, I think I have this position for a purpose. It's not simply just to be comfortable and have a happy life. I mean, I feel some sense of responsibility to just express what my ideas are on this. I mean, I may be right, I may be wrong, and of course, it's for folks who are listening to decide. But I mean, I think we all, as academics, have that responsibility to say what we think. Actually, it's been discouraging to me see both economists and non-economists and other scientists. I thought that we were in a liberal profession, liberal in the sense of like open free exchange of ideas, we're not aiming to like destroy one another. We're aiming to learn from one another. I mean, I might be wrong. You'll teach me something, Russ, and I'll change my mind. In fact, you've done that with your writing all the way across. So I think that sense of like humility and sense of desire to learn from one another has been, I think, utterly crushed in this epidemic. That's been disheartening. A lot of the reaction to the Great Barrington Declaration has been to mischaracterize it as a herd immunity strategy, which at this point I think of as a propaganda term, where the idea is, in fact, you see Dr. Fauci say this as it's a let it rip strategy. And if you've been listening to this conversation so far, you can probably you hear it. I don't want to let it rip. That is the farthest, from my mind. I think the key thing is let's take the costs and benefits into account very carefully and protect the vulnerable. That's really the key idea of the Great Barrington Declaration. To call it a let it rip strategy basically is a desire not to engage with the ideas. And that is an illiberal, like we've seen this instinct. It's an illiberal instinct. We've seen this with like the reaction, for instance, to Scott Atlas. Right? Scott's saying some things. He may be right, he may be wrong. He has a very, very difficult job advising the president. How do you react to that? If you think you don't agree with them, well, I would, as someone who, as someone who's for your science, you don't agree. What do? You write, okay, here's what I think is right. You don't attack the person, try to get them fired from a place, or what you do is you say, here's what the evidence says, and we can have a discussion. That sense, I think, has been lost. In fact, there was a move. I wrote a textbook on health economics. There's a movement by some economists to try to get people to boycott the textbook, because I wrote the Great Barrington Declaration. It's like, if I write paper A and you agree with it, Russ, and you cite it, then I'll write paper B and you don't agree with it, and then you stop citing paper A as a result. That's harmful for science.
No, I agree. I think it's, a lot of it is this tribal moment that we're in America and in the world. We've talked about a lot on the program, and it saddens me deeply. I've talked about it before, that the idea that masks are a partisan issue is grotesque. It is the premier proof that we've gone off the rails as a country, that's a way we express our ideology and partisanship, is whether we wear a mask or not. That is lunacy. It is so sad to me. And here's another example you're talking about, which is we're in the middle of a horrible situation. Nobody's pretending that it's made up. It's horrible. But to suggest different ways of dealing with it than how we have dealt with it cannot be discussed among civilized, thoughtful people in many cases. And talk about how the internet has responded. I've read, I don't know if it's true, but that if you search for certain things now, that certain things have been taken down off of YouTube, or you can't find it on Google. Has that been part of your experience also? Well,
when we first put out the Great Barrington Declaration, Google shadow banned it.
Google what?
Shadow banned it. So if you typed in the Great Barrington Declaration, up would pop like 15 hit pieces, and you'd have to go to page 3 or 2 or whatever to actually get to the site. I think they fixed that now in the U.S., but a lot of countries, they still have that. Like if you Google it from Slovakia, you'd have that issue. I don't know if that's still true. I think that sort of fixed itself. But videos of prominent people, have been suppressed on YouTube. John Ioannidis talking about this. John Ioannidis is a very, very prominent scientist here at Stanford.
Former guest of EconTalk, past guest.
Brilliant man, right? And he may be right or wrong, but to not allow people to hear him on YouTube is nuts. I think that Michael Yerdon just had to put out he's another immunologist and infectious disease doctor in the UK, just got suppressed by YouTube. How do you have science if you don't have people who are willing to say something that's different than what everyone else is saying? You just can't have science. You may as well just close up shop. And the public sort of mechanisms of disseminating people's views, in the modern ones, Google, YouTube, Twitter, have an absolute obligation to allow that to happen. And I understand they're private companies, and we can talk about whether, but right.
Tougher question.
But if they're private companies, they still have a public obligation, given the role they play in American society and world society, to allow that. I mean, it's a very illiberal instinct. I think we can all agree, even if you think that that private companies can do whatever they want, it's still I would characterize an illiberal instinct to sort of suppress that kind of conversation.
Yeah, no, it's deeply disturbing. It does raise interesting questions over who should have the right to constrain the spread of information, whether it's private companies, they should be free to do that and thereby damage or help their own brand.
But I mean, I'm less interested in the economic fight over competition on this, rather than like as a society,
cultural.
Yeah, I think that liberal norm is at the heart of. I mean, I'm at a university where the motto is "Let the winds of freedom blow," and I'm afraid that they're not really blowing that hard anymore here.
Yeah.
I think, and I think that's true worldwide. I think we're sort of in an illiberal moment, and figuring out mechanisms to get back to a liberal society is going to be very, very important.
I'm not sure we can get there from here. I think there's what's gone wrong with the ability and indulgence in tribalism that I mentioned earlier is I'm not sure we can put that horse back in the barn. We got a real tough road ahead of us in my view. Let's close and talk about vaccines. What are your thoughts on where we stand? Again, we're in November. The Moderna and the Pfizer vaccine have had very encouraging early results. We don't know what their safety is. The efficacy numbers of 90 and 95%, when you look at what they actually are, not quite what the average person thinks of when they think of 95 or 90% efficacy. It's a really particular technical definition that's, to me, not so helpful. But they seem to be. There's a lot of optimism about them. Will this, if they are available, will this change everything?
So yeah, I mean, I think they will. It depends on how we decide to employ them. Let's take as given, obviously the data still haven't come out, but let's take as given that they're safe and very, very effective, right? So just how should we use them will become the next question, because the key constraint is getting sufficient. I think each vaccine you have to have 2 doses. So with Operation Warp Speed, we'll have something like enough doses for 35 to 50 million people.
Correct.
And then we'll have to wait a long time for there to be sufficient number for the whole world to have it, right? So the question is, how do we use them? I think the right answer is the focus protection idea inside the Great Barrington Declaration. In fact, it's if again conditional on us assuming that the vaccine is safe and effective in these populations, you give it to the people who are vulnerable. That's effective protection. Now they're no longer at risk from or such high risk from disease should they get because they're much less likely to get it. And then for the rest of the world who are not vulnerable, the disease is worse than the lockdown. So it's a perfect tool for focus protection, actually, if we choose to use it that way. The other alternative I've seen, and people have said this, is, well, why don't we just wait until if we have enough doses for everybody and then open up the world, another 6-9 months of lockdown, as if that were the safe option. It is not the safe option, Russ. That will devastate the world in ways that we've already become familiar with, but even worse because we're already poor as a result of the 10 months of policies we've adopted. So I think that's the debate going forward: is how do you use that vaccine correctly? I think the right choice is focus protection.
And let's close with the next time, because there will be a next time, almost certainly, probably in our lifetimes, more likely in years than mine. But I'm not 70, Jay. I'm good. I'm fine until I got 4 more years. I really worry. I just think funny, the whole thing is like, it was 65 for a while was the cutoff when you had to be worried. So I was 65, right on the cusp. And then I turned 66 in September. Trouble. But it is a fairly smooth line, as it turns out. It's not a hard cut at a particular age. But we're going to get another one of these. And one thing I think is tragic about this whole conversation, national, international conversation, is that, again, for social, partisan, ideological reasons, we have not talked about the role of China as a nation in this. I mean, the president did a little bit, and because it was him, then it went off the table for a whole different group of people. He didn't talk about it well, I don't think, or appropriately. So it's just a tragedy there. But the fact is, this disease came from China, as far as I understand it, and we've not been able to investigate in an open way why that happened and thereby potentially reduce the risk of it happening again. So that's a separate issue. Forget about that for now. It just really makes me sad and maddens me. But it will come again, almost certainly. When that happens, what would be your hope? I guess the problem is that the profile will be different in terms of who's most vulnerable, and so we can't really generalize until we get the information we need from the beginning. So I guess my personal view is that we've done a terrible job generating the information people need to make the decisions that they would make as their own choices about risk. That should have been a priority. Instead, we have the CDC making pronouncements, which sometimes have been literally absolutely wrong and degraded their own institution. But what are your thoughts on the next time, what we should do from what we've learned so far?
I mean, it's very clear that our infrastructure for generating knowledge rapidly at a population level is really poor in the United States, and actually a lot of countries, but certainly in the United States. I think in some ways science has done really well. I mean, the fact that we have a vaccine so quickly is an absolute miracle to me. I mean, if you asked me, infectious people did at the beginning of the epidemic, how long would it take to get a vaccine? I said several years, because that is the norm for vaccine development. This is an absolute miracle. And actually, the other thing, scientific knowledge about this, I sort of underplayed it when you asked me initially about this, because I was focused on my own work. But I should say, the science on this has been fantastic. Like a lot of the knowledge about T cell responses, about sort of treatments and so on, have proceeded at a very rapid pace, much more rapidly than I anticipated early in the epidemic. So I think in that sense, we've done well. We've done very poorly in population epidemiology. And that's partly because how we like, for instance, when we track the flu in the United States, we have a few sentinel labs that we get the flu tests from, and then we decide that we extrapolate. As economists, we're used to like very large scale surveys to track unemployment at the monthly level, like the current population study. Why can't we have something like that for disease epidemiology? And have it be flexible. So you have this massive panel of people that you go to. You can take blood from them, or hair samples, or whatever you need as the new diseases come up, and very rapidly deploy it. I think the other thing we kind of talked about is this sort of like we have to be very clear about our goals as a CDC or whatever, as in public health, right? So the goal has been muddled from the beginning. There's essentially this like fight between zero COVID and learning to live with it. And if you don't know what the goal is, you can't have a good policy. I think a lot of the muddle has to do with that. The science communication should be absolutely fundamental part of any public agency that's like the CDC. Like so for instance, like I just saw Director Redfield say that the CDC never said to close schools. You couldn't have told that from their pronouncements from the epidemic. They've closed. Dr. Fauci panicked the country over a relatively rare outcome from a few kids getting the disease. He called it Kawasaki's, now it's called MISC. In any case, that kind of mistake is absolutely devastating to trust in public health and also to public policy outcomes. I think there does need to be reform at the CDC and in public health more generally. To like have better systems of tracking disease, and B, to sort of, I mean, I think economists really should have a role here. Economists that have some sense of like, look, there are trade-offs to what you're doing. And so there should be someone at the table saying there's trade-offs to what you're doing. What is the goal? These are tools that economists just have naturally. And if I ever get my economist card back, I'll play some role with that.
Well, I think I burned mine long ago, but I just want to say one thing about the pharmaceutical industry, because I think it's important. I don't know if I've said it on the program, but what I have said on the program many times is that, and we've had many guests talking about this, the current way that pharmaceutical research is structured in a way to allow pharmaceutical companies to reach into my pocket and subsidize marginal, tiny improvements in health at enormous cost to me and very small gains to the recipients of those pharmaceuticals who don't have to pay for them because the way we've set up Medicare and so on. And I think that's an intellectually bankrupt system, dysfunctional. And of course, with that, we get some wonderful things from the pharmaceutical industry as well. But there are two, to me, we get very bad bang for the buck for the average pharmaceutical dollar, even though I concede that you can't say what those are in advance, and therefore it's good to try lots of different things. But we've set up an industry where a lot of the things that we do get out of it, I don't think are worth what we pay for as taxpayers subsidizing Medicare for old people. Having said that, because we have done that, and I have mentioned as I have family in the pharmaceutical business in labs, so I say what I said just a minute ago, well aware that that is bad for their, if my view is embraced, it'd be bad for their well-being. Having said that, the large cadre of chemists, biochemists, and the infrastructure of the large pharmaceutical world that we have in the United States is what has allowed this response to happen of 9 months into a tragic pandemic. We have 2 vaccines, and there are more, and then we're going to have more, I have a feeling. And, you know, I like to quote the Kipling poem. It's Tommy this and Tommy that, and Tommy wait outside. But it's thank you, Mr. Atkins, when the ships are on the tide. Meaning, in England, when you're a soldier, you don't get much respect. But, you know, when there's a war, all of a sudden you're important. So, you know, for all my criticism of the pharmaceutical industry, this is a glorious success on their part. I'm glad they're making a ton of money from it, and I hope they do. You know, a lot of voices out there saying, yeah, well, now they found it, we should take it away from them because they shouldn't be allowed to make profit from it. It is that profit and the past profit, which I have somewhat decried, which has allowed the stable of intellectual firepower that they have unleashed on this virus. And it's a glorious moment of human achievement. And I hope they make a lot of money from it because they should. And then in the future, I think we should scale things down. But you want to react to that?
Let me say something slightly smaller, but I come in line with your. I mean, I think there's very little incentive to explore small molecules that are off patent, and we don't. You know, the NIH in principle could solve that problem. That essentially like that. It's a market failure problem, right? So because no one owns that intellectual property. But I mean, I don't know the right answer to this, but like there ought to be. Like if you think about the controversy over hydroxychloroquine, you know, it's a cheap small molecule. There really hasn't been a ton of evaluation of it, and there's just been this like huge controversy over it. I mean, this is something where you could answer the question if someone had the incentive to do it with a simple trial, right? And there's been a few, but not a ton, sort of on point. There ought to be incentives to explore those kinds of ideas rather than just ideas that are on patent.
Well, those incentives don't have to come from the government. There's a lot of wealthy people who care a lot about this, a lot of foundations. They could fund these kind of more thorough studies. And I think they're going on right now. I think we'll learn some things we don't know yet from those efforts. So there's some hope, but it's not a good system right now, the way it's structured.
Yeah, I agree.
You want to close? Take us home, Jay. What do you got to say? Give me some optimism or something you've learned from this that you've grown from. Maybe you're a better human being because you've been beat up. Your seroprevalence story, which we didn't talk much about in detail. I know you took an enormous amount of abuse for that study.
Let me end with hope, Russ.
Okay.
I think that I think that if we adopt good policies going forward, we can prevent a lot of the harm that lies in front of us. The vaccine is a godsend, and we can use it to reopen society if we choose to do so. And I think that's my hope. Like I think if we think carefully about the costs and the benefits, we actually can get back to a place where we can start arguing about, are the pharmaceutical companies too rich? I mean, we can start arguing about, should it be private? I mean, all those arguments are fun, but here I think we're at a crossroads of our civilization. Essentially, I think about these lockdowns as the nuclear bomb of public health, of epidemiology. It's like physics coming into fruition with the actual nuclear bomb when it was dropped on Hiroshima. We've dropped a nuclear bomb on society, and now the question is, how do we go forward? We've structured our society so that we minimize the chance of that nuclear bomb ever being dropped again. The physical, literal one. We fought a Cold War designed around not dropping that bomb. I think we should do the same with this. That's my view now, and I think we can. We now have the ideas, the technology to when the next thing happens, we'll be we could be in a much better place if we just choose to do so.
My guest today has been Jay Bhattacharya of Stanford University, co-author of the Great Barrington Declaration, which we will link to so that you don't have to Google for it. And Jay, thanks for being part of EconTalk.
Thanks, Russ.
This is EconTalk, part of the Library of Economics and Liberty. For more EconTalk, go to econtalk.org, where you can also comment on today's podcast and find links and readings related to today's conversation. The sound engineer for EconTalk is Rich Goyette. I'm your host, Russ Roberts. Thanks for listening. Talk to you on Monday.